Hello, Martha.
Hello again. Hi, Julie.
Hi, how are you?
Good.
Hi, Julie.
Hi.
So we will wait until more people join and then I'll share the slides.
I'm not seeing a chat button on mine. So I can see.
It's along the top. There's a lot where it says leave, then there's share, mic, camera, more apps, rooms, all the way over, and chat should be right there.
I don't have anything at the top. Let me fix one.
Yeah, I also see it on the top of my screen.
You might want to leave and come back and see if it pops up, possibly.
It wasn't on there the last time I was on either. So
How odd.
It says Julie has temporarily joined the chat, so it seems like you're there.
Oh, here we can. Yeah, let's put something in chat. Yeah, it says you're in there. Hold on, I'm gonna put hi, Julie. See if
Hi.
you can see it.
Do not.
See the chat? No. Huh.
Okay then. I can raise my hand. Oh. Mine's broken.
Well, I can monitor it, Julie, don't worry.
Okay.
Hey, everybody.
Hello.
Hello.
Hi, Naftali.
Hello. I forgot who's leading us off here today.
So I think Jen will just give us the green light, and then Julie will start.
Okay, great.
I will be managing the slides. And then you and I will continue monitor the chat because I think Julie is not able to see the chat for some reason.
No problem.
I'm doing a quick Google search to see if I can figure out how to fix it.
Hi, everybody. We're just going to wait for a couple minutes for everybody to log on, and then we'll get going.
Yeah, don't worry about it, Julie. We can handle the chat. We often split it up that way anyway.
everybody. I think we are going to get moving since it is 1:01. And I am going to turn it over to Julie to start today. Welcome to our 6th installment of Integrated Behavioral Health Team Training. Glad to have you all here. Thank you for participating. Hi, John. Nice to see you. And we will kick it off. Believe, Julie, you're going to take it from here.
Sure. Hi. Today we're going to talk a little bit about billing, and as you guys start to think about billings for some of these integrated behavioral services, you need to assemble your team, and you need to think about who you need to have on your team to assure that your note includes what it needs to have so that you can get reimbursed. That when you that you're required to drop a billing code, that you have a diagnosis, you have a start and end time, and folks from your billing team ought to be able to help you with that, as well as IT. So they're going to be integral to making sure that your codes are built properly and that you're able to get reimbursed. You may have new billing codes for integrated behavioral health that your system hasn't used before. And you may have providers that haven't billed in your system before. For example, if you've only used social workers and you now have psychologists, or you've never had a marriage and family therapist. So you'll want to have those individuals on your team to help with those things. You also want to talk about how do your billing codes flow and who tracks whether they're reimbursed and who follows up on denials. You want to talk about where the funds flow. So who's receiving the payments? When we set up integrated behavioral health, they were flowing to primary care. Primary care was very happy about that, but when we couldn't really track our outcomes because the dollars weren't flowing into our budget, they were less happy about it when the dollars were moved. So think about how that flows through your system. And if you're going to drop non-billable codes for contacts that you just want to document, but there's no code attached to it. And then you want to think about how your billing codes help with your metrics. Metrics are important to sustainability. Regular reporting is important to be able to tell who and how many patients you're seeing, what part of those services are reimbursed. You want to talk about the reporting for productivity. You can see how much penetration you have within the clinic. And all that comes from the initial build. So you'll want to make sure that your team has got all of those individuals on it when you get started. You might also think about having somebody that negotiates with your payers on the initial conversation so that they really understand the model that you're using and what your expectations are about reimbursement. So some of the billing considerations that you want to think about. In box 1, we've got the credentials of your providers and the rules of the payer. Those can be different based on who is paying for the services. Medicare limits some behavioral health reimbursement to specific providers. For health and behavior codes, only for Medicare, only psychologists can bill for those. So you'll really want to understand the rules of your payers and what credentials you have on your team. Payers specific codes and site of service. There are some codes that depend on where the service is delivered, whether it's an FQHC or whether it's a commercial provider. Some codes are restricted. They're only useful to FQHCs, so you need to understand what your codes are and who your payer source is again. You need to understand who provides the service and to whom. Is it an individual service? Do you have family? Are you offering groups? There's care management codes for some behavioral health. So you need to, again, understand just who's doing what and to whom. And then think about the length of service. Some of the codes are time-based and some are threshold-based. When we start to talk about collaborative care codes, some of those have specific thresholds that have to be met per month. And then think about whether the actual provider, the behavioral health provider, is billing. Are they billing incident to, as in collaborative care? Many systems are familiar with incident to for nurse practitioners or physician's assistants, but not so much with other providers. Next slide, Martha. So common codes billing for behavioral health and primary care There's traditional mental health codes. There are health and behavior codes. There are alcohol and substance abuse services, collaborative care codes, and then newer codes that have been approved since the pandemic are telehealth, behavioral health codes.
So let's talk about the mental health codes. You'll see here 3 sections. We have the initial assessment. That's the code that you'll see over there. But then I'm gonna, as some of you know, I practice in a FQHC here in Wisconsin. So usually what we do in our primary care behavioral health model, we typically use the individual therapy codes, which is the first 2 ones, which is the 30 minutes which is 16 minutes or 37 minutes, or more than that will be the second code with the 45 minutes. Those are, I can tell you, like the 95% of codes that we use are at clinic. We don't use the initial assessment. I know for some sites this might look different depending if you're not in a FQHC or so, but like I mentioned, the ones that we use the most are the individual therapy, 16 minutes and more, or 37 minutes and more. We have here also, just for you guys, for the information, we have the family therapy codes, but those are codes that in our FQHC wouldn't use very often.
I'll just add a little bit of nuance to the requirements there. So the initial assessment, if you're going to use that code, it can be a little tricky to know what the requirement is for coding it, because it's not just time-based. It's not time-based at all, actually. It's based on the nature of the content of the visit. Most payers use Medicare, the Medicare definition of what should go in a 90791 visit. And it's actually not as expansive as many centers make it out to be. In specialty mental health settings, oftentimes an initial assessment will take an hour, hour and a half, sometimes. But given that you have Head Start usually with the patient in a primary care setting, because you have a lot of information already in the EHR, the requirements that you need for documentation for that visit, you can often get it done in a half hour. It's just requirements like social history, family history, medical history, and other aspects of assessment, substance abuse. And so some people in integrated care settings will develop a template for the initial assessment. Now, in order to do that, in order to build that 90791 code, and in general, that 90791 code is usually paid out at a higher rate than the 908 series codes, but it's often not terribly helpful to distinguish that and separate that out. And because typically in the PCBH model, you're always doing some form of assessment and intervention at every visit, this coding structure really just doesn't fit the model very well. So more likely than not, we would encourage folks to simply utilize the 908 series codes and skip the 907 code altogether, as long as your situation allows it, and Wisconsin does allow it as a state. So I practiced for many years in Wisconsin. I never used a 90791 90791 code. Another little nuance there, if you are going to use a 90791, lots of payers restrict how often you can use that code because it's supposed to be an initial assessment code. So a 90791 code, you typically can only use once a year. And if it's done in a subsequent year with the same patient, there has to be a good rationale for why you are reassessing that particular patient. So just something to keep in the back of your head. So by and large, as Martha said, that 908 series codes, this is like the bread and butter of most PCBH intervention, it's going to be 908s. One of these, actually, literally, it'd be the 90832 and the 90834. That's like most of which are going to be billing out. Last but not least, I'll just mention this just to be clear. These codes require a mental health diagnosis, right? So remember, you're pairing a CPT code with a diagnosis, right? ICD-10 diagnosis typically in your settings. So that's crucial, right? You're not going to put a medical diagnosis, and oftentimes you are not going to be able to put Z codes or F codes, Z codes, or other codes that are sort of non-clinical diagnoses that are part of the ICD-10 or the DSM-5, because payers typically won't pay out for those codes. So you have to have a clinical diagnosis, you have to have documentation that supports it, and for these codes, you have to meet the time criteria.
So going with when Natalie said that you need to have documentation that supported, remember that last month we talked about documentation, and our template was actually built up to kind of fulfill the requirements, particularly Medicare, when it includes, the diagnosis and the time and all that. So just remind you all that this is a continuation of what we were talking on our previous month in regards to documentation. And well, now we have the health and behavior intervention codes, which these are going to be different than the other ones that we mentioned before. The mental health codes is the focus of the assessment is not on the mental health. It's got to be more on the biopsychosocial factors important to the physical health problems of a treatment of the person. So for example, someone who's dealing with hypertension, diabetes, those are the health and behavioral codes that we will be using. Although I have to highlight that in Wisconsin, Medicare allows licensed clinical social workers and psychologists to bill for these codes. Medicaid, but Medicare will just allow licensed clinical psychologists only. So again, like Julie mentioned in the beginning, it's important that you get in touch with your billing people to review what are the licensure of your team and who can bill for what, and what are also the majority of the population that you're serving. Like if are there with private insurance, or are more Medicare or more Medicaid. Those are important questions you need to ask when you are reviewing the codes. And going to my next slide here, we are seeing here some of those, like, the assessment, what's the code that you will use. The individual intervention, when it's regarding about the time, 30 minutes. And when you add more than those 30 minutes, 15 minutes more, you can see the codes there, 96158 or 96159. There's group interventions. There's family interventions, and then below you're going to see the smoke and tobacco and cessation visits, which if you see at the time, we usually, when we do a very brief session with a patient, just introducing them to smoke cessation, it can be billed between 3 and 10 minutes. It's just more than that. There's a different code that you will use. But we have to really highlight that it is basically just working and helping the patient to improve their health in that health and behavior code, which means, for example, someone who has diabetes, there's no signs of depression or anything like that, but they're having a hard time adjusting to maybe applying their insulin, every time after a meal, and you're working just basically just on that. These are the type of codes that you can be using. Although I have to tell you that through my experience, it's rare that I will use these codes, because most of the times there's a mental health diagnosis attached to either depression or anxiety or any other mental health diagnosis that it's together affecting the health of the patient. So yes, we use them, but I can tell you my experience is very, very rare.
I'll add a point of clarification. I'd forgotten, if you go back to that slide real quick, I realized that we didn't update a portion of this slide. Technically speaking, for the 96158, to bill that service, you have to have had face-to-face time with the patient for 16 minutes. So they changed these codes in 2020 to align more with the psychotherapy code time structure. So just like with the 90832, you can spend 16 minutes with the patient and bill that visit. I think it's between 16 and 34 or something like that. So just be aware that that time structure is a little bit updated. For 96159, it's 8 minutes or less of service, but that's only in addition to the 96158. So anyway, we will send you, there's a nice little explainer online about these codes so that you know. The other key thing to remember this from a billing standpoint that often trips people up, that's different about the other codes. Like, so with the psychotherapy codes that we talked about before, that's another name for them. They're time-based, and so you just would, if you'd spent, 20 minutes with a patient, you code the 90832. With these, you're coding in increments. And so on the billing side of things, that looks a little bit different as far as how you count these units of service. So your billing people on the back end will typically create these codes and put them in these units of time. So it'd be like if you had 2 units of 96158, for example, right? If you spent an hour with the patient, it'd be 2 units of that you would code. So that's just a nuance that sometimes trips up folks. But there are other things that the billers do that are like that are billed in units. And so as long as they understand that, they usually get it like, oh yeah, we know how to do that kind of a thing. Just remember that this is billed in those units of service. And I'll actually put in a chat the link to the reference document for this.
So also in primary care settings that people are doing screenings for substance abuse and alcohol services. An evidence-based early intervention approach for non-dependent substance users is called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. In order to bill for this approach, you have to use a SAMHSA or WHO endorsed tool like the audit or the DAST. The diagnosis is substance use disorder, mild, moderate, or severe. The brief intervention would be to increase awareness, provide feedback, do some motivational interviewing, and then referring people for additional treatment if necessary. Next slide, Martha.
Yep.
So here are the coding, depending again, as we spoke earlier about the payer, these codes are divided into the amount of time that is spent and then which payers you're billing for. In addition to that, there are H codes for alcohol and drug screening. Medicare covers 1 screening and 4 brief counseling sessions annually at no cost to the patient. And some of these codes are also state dependent. And now we're going to talk about a little bit about the collaborative care model. And this model is out of the University of Washington. And it is a registry-based way to care manage patients that have depression specifically, but it's also been used with other diagnoses. The model includes a BH care manager. It includes the primary care provider who maintains responsibility for the patient, and then a psychiatric consultant, and the team also includes the patient. It is a registry-based approach, so if a patient came in to see their primary care physician and they were either started on an antidepressant or maybe they were struggling with an antidepressant, typically they're screened using the PHQ. There's a cutoff of usually 10 that gets people offered into the registry. Patient has to consent to be part of the COCM, collaborative care management. And then the patient is then referred to the behavioral health care manager, who will do a series of validated screens to track the patient's progress. For patients that there is not improvement, the psychiatric consultant then reviews the chart, typically, rarely sees the patient face-to-face, but then speaks with the care manager and reviews the registry on a regular basis. Next slide, Martha.
Sorry.
It's okay.
There you go. Oops, I went ahead. There you go.
Stop there. So the initial assessment, again, is with a validated rating scale that can either be done by the primary care provider side or by the care manager. They jointly care plan with the patient. The patient must consent to a possible copay, again, depending on their insurance, and then for the psychiatric consultation. The patient is then entered into the registry and then is proactively, and I think that's important, proactively tracked with serial rating scales. The behavioral health care manager may assess treatment and medication compliant. They may deliver brief interventions to see what's getting in the way. Is the patient taking their medications? Are they doing other behavioral activation sorts of activities? Again, that's regularly reviewed with the psychiatric consultant, and then the medications are generally written by the primary care physician and adjusted by the primary care physician. The codes that are used, and this can get a little bit tricky because these are threshold codes. For the most part, there is one code that is not threshold coded. To use these codes, you have to have a registry in place. It can be a formal registry or a more informal registry, like an Excel spreadsheet. The first month, there has to be 7 minutes of activities, and that includes anything the care manager does, the primary care team does, conversations between them, consultation with the psychiatrist, all of that has to be documented. The following months, 60 minutes of activity, 30 minutes of additional activity, those are add-on codes. And then there is a general BH code that can be used for any month. It doesn't require the care manager or consulting psychiatry. And that can be a physician talking with the patient or calling patient to check up on them. These codes, in order, again, to build them, they're threshold activities. So there has to be some structure in the background to be able to track these services on a monthly basis in order to be able to bill.
Yeah, and you mentioned, Julie, before that these are incident to, so you're actually billing through the physician's number, so that the care manager, for example, is not billing independently. The consulting psychiatrist is not billing independently. This is billed typically through the physician who is essentially in charge of the care. And so in the documentation in your EHR, you would be accounting for the phone calls or other contacts that the care manager has had, the conversations had between the care manager and the consulting psychiatrist and or the primary care provider. And so it just accounts for the time spent, and then it gets billed through the physician as a unit of service for that month. One piece that Julie mentioned that's really important not to overlook is the potential copay issue. So because this is a different kind of service than most patients receive in the clinic, you know, patients are more familiar with a fee-for-service type model. It does take some good onboarding of patients to educate them about here's what the service is that you're going to receive by participating or enrolling in this program. So you have to really, on the implementation side, make sure that you're educating your teams and whoever it is that's going to be introducing these services. Often at a minimum, the primary care provider, but sometimes the primary care provider handing off to the care manager to come in and do that enrollment. Otherwise, patients might be pretty upset if they get a copay and are unsure of why they got that copay and why they're paying for this, this service.
And just some additional considerations for COCM billing. Both the care manager and the consulting psychiatrist are able to bill traditional mental health codes as well, if all of the conditions for those are met, but then they cannot also use that time to bill the COCM codes for the threshold. The qualifications required are formalized education or specialized training in behavioral health, not an independent licensure. However, if you don't have independent licensure, then you can't bill the codes for some payers.
Yeah, that's a great point, Julie. And just to highlight that, the care manager in the COCM model can be anything from a bachelor's level individual to a master's level mental health professional to even at times a nurse, an RN. And so because of that, the COCM codes don't specify a particular license that's required. And because of that also, the nature of the intervention that the care manager will apply will differ. It can be anything from just basic phone call check-ins to pretty in-depth CBT to even in some cases, brief intervention and psychotherapy services. But that's dependent on the training and license that the care manager has, essentially. So that's why implementation looks different site to site, oftentimes based on the skill level of the care manager.
So specific, the billing basics for Wisconsin Medicaid, which is estimated to start in June, the primary care billing provider must be in Medicaid. Psychiatric consultant must also be enrolled in Medicaid. The care manager must have a bachelor's degree, but does not have to be enrolled in Medicaid. And then the codes are listed below that.
And again, this is a very fresh news. So I'm sure that as soon as some sites start rolling this out, there's going to be, some bumps and hoops that they need to be addressed. But it's a good news. It's a good news that in the state of Wisconsin, we're going to start billing for COCM. And then we have, we probably everybody know after COVID, there was the news of that telebehavioral health codes that they were able to be used. And these are the codes here between the times 5 to 10, 11, 20 or more minutes with not physician telehealth assessments.
Martha, you gotta move the slide forward.
Sorry, I move it in my other screen, but not on your screen. There you go, guys. Sorry about that. I will continue to highlight the importance to, again, meet with your billing people. I can tell you, like on the side that I'm working, for example, usually when we are doing a telehealth visit and we go over the 16 minutes, we will use the psychotherapy regular code instead of a telehealth behavioral code, even though if it's a telehealth session. When there's intervention, there's a plan, there's an assessment. So it's just when we met with our billing people, it makes sense for them and it was okay to do that. So we're showing here all the codes, but I think it's super important that you always have that communication with your billing department just to make sure what makes sense, what's best for your site, and particularly with the population that you are serving. And with that, I think we are done with, going around all the billing codes that we wanted to show out to you. Sounds like a very dry topic, numbers and times and check boxes, but it's important. However, I also want to emphasize what we mentioned in our last month meeting, that it's important that sometimes I think these topics can get us anxious as to whether we're doing things right or not. but a lot of the times it's just how to play the system the right way, the smart way. Like Naftali was mentioning early, when we do the code for the first intervention, even though it can pay a little bit higher, sometimes we know that it's not worth it, to use it, or doesn't make a big difference. And it has more requirements that you cannot use that code more than once a year, and other things that it makes sense just to say, hey, we're not going to use that one. We're just going to do the psychotherapy of 16 more minutes and more. So just to have that conversation with your team, with your billing department, makes a lot of sense.
So we have a question in the chat, and definitely feel free to put questions in the chat or to raise your turn on your mic. And this is a very good question from Heather about whether psychotherapy codes, that's those codes that Martha was just referring to, the 90791 and the 908 series codes. Does a clinic need to be DHS 35 certified? Meaning, does it need to be a licensed mental health facility in the state of Wisconsin? And the answer is no. And the reason is because even though these codes are called psychotherapy codes, that does not mean that what you are providing is psychotherapy in the sort of traditional sense. It just means that, first of all, that's just historical, because in the past that's all we had, right? All we had was specialty mental health, and psychotherapy was a thing that was done. What we are doing in integrated care is providing the same types of interventions based on the same evidence and meeting the same requirements that the code requires in order to support patient care. So it may not be psychotherapy per se, right? We may call it, I like to call it targeted intervention and assessment, but it's the same stuff. We haven't made up something different, right? And so that's why payers have, for many years, in my entire 20-some years career, not made a distinction necessarily between providing these services in primary care in a PCBH model, for example, versus doing it in an outpatient psychotherapy office. In fact, we generally recommend that you do not become DHS 35 certified, because it comes with a tremendous amount of regulatory baggage when you do so. There's more requirements as far as what your facility should be like, what your documentation should be like. There are more rules around maintaining separation between your mental health documentation and your physical health documentation. You're subject to audits from the state for all of this. And so we haven't seen much of a benefit, frankly, for sites to become, for medical sites to become state certified in any state, let alone the state of Wisconsin. In fact, we worked with one clinic where we successfully convinced them to decertify as a DHS 35 clinic, and that helped them tremendously. So yeah, that's the long and short of that. Any other questions or thoughts about this very fun topic of billing?
So even this is John from Pro. Even without the certification under DHS 35, you can still bill the 90791s, the 90832s, etc.
That's right. Yeah, most mental health professionals in the state of Wisconsin are not part of a DHS 35 certified clinic. If you think about it, right? If you have your own outpatient practice, like there's lots of people providing mental health services that have nothing to do with being a state licensed facility. So again, the only advantage that you may have, and there's actually been some lobbying to try to switch this up, is that there are some payment mechanisms that those clinics have for paying trainees. But beyond that, there's just not much of an advantage for a primary care clinic to become certified. It's just asking for more regulation and oversight is what it's asking for no reason, really.
This is Julie from Theta Care. Can I ask a follow-up question to that?
Sure.
So at Theta Care, the collaboration managers that we have integrated in primary care work for our behavioral health department. So they're, you know, for all intents and purposes, like an arm of our behavioral health department. So would that still hold true then about DHS certification and that psychotherapy function?
Is your behavioral health arm DHS 35 certified clinic service entity?
Yes, and then all of our like branch locations where we're doing psychiatry, psychotherapy, or substance use are certified.
So this is a gray area that
Yes.
is not settled. A lot of people think that if you ask, you're going to get an answer to that. And I say you ask, you will get an answer that day from that person.
Okay.
And again, this is where you would want to consult your own lawyers about this and not listen to Dr. Serrano's legal advice. But what I would suggest is that if you're going to try to ride that line in order to not have that personnel that's embedded in primary care fall under that you would actually transition those folks to the employment side of the medical service. In other words, I think I would guess that the state would consider all of the folks employed and administered by your behavioral health side to be under their jurisdiction or under the certification process. And so if they are employed by the behavioral health side, that can be problematic. So does that guarantee that that's going to fix the issue from the state's standpoint? No, they could choose to do whatever they want and pursue you for whatever reason. But you're going to have a lot better chance at drawing that line and making a good argument to the state if you say, well, look, we've got two separate arms here, and we've got employees here and we've got employees here, right? Because they certainly aren't regulating your medical side.
Right.
That's for sure. That their jurisdiction does not cross over onto your primary care side. So if there's an employee of primary care, they would have to make a much tougher argument that they have oversight over that employee there. Make sense?
Yes, definitely. I would agree with that.
So we're actually working with a clinic right now in Milwaukee that's in this same situation. And so that's the guidance we're providing them around just making sure there's some clean boundaries between their specialty mental health services and their integrated services that should be within the hierarchy and administration of primary care. So this is not theoretical for us. We're literally working this out with folks.
Are you seeing places that are actually using bachelor's level providers within that collaborative care model?
Not as many as you see master's level folks. And the reason is that if you really want to be providing robust behavioral intervention, theoretically you can train health coaches at the bachelor's level, and you can train folks to do very basic behavioral activation type strategies, maybe even some basic CBT, but to have that knowledge and awareness to manage the registry effectively, work with the primary care team, work with a consulting psychiatrist, you would need an exceptional person at the bachelor's level and a well-trained person to do that. And those people are typically moving up the ranks anyway in their career to move up into that master's level anyway. So No, I don't see that as much as I see a master's level clinician filling that role.
Yeah, I was going to say just as much supervision as I see sometimes even master's level folks, that are just coming into the field, that even they need at times. I would, and if the psychiatrist is the only one, I mean, not that there aren't psychiatrists who aren't good supervisors, there are, but a lot of them, that's just not their bailiwick. And if I would see there would be a real potential there for problems.
Yeah, absolutely. And some of this is just recognizing that in some
Nobody else has other stuff.
Yeah, in some COCM implementations, the care manager does sort of a very limited scope of practice. So they may be like just, again, sitting in front of the registry and ticking off which patients need a follow-up phone call and checking in on their medications, re-administering a PHQ-9 to assess for symptoms of depression, and then just doing basic communication with the care team. So they're just like making these phone calls to folks. So at a very basic level, that's some versions of COCM. I would say that's a very substandard version of COCM. That's not really terribly ideal. Most implementations now are really looking at providing a much more robust, it's almost like having in a PCBH trained individual in that role who's able to provide brief intervention, operate independently, and then pull in the other team members as needed. So yeah, that's just the nature of the range of implementations that people have across the country.
With that, I want to add, we do have an extended training program at our site for the PCBH model. And we usually have master level students or postdoctoral students and going connected with the billing in order for a student to be able to bill when they see a patient. A supervisor needs to be present in person in the session 16 minutes or more. So the way that we do it is that once we feel the student is ready, they will go to see the patient, will jump into the room for 16 minutes or a little bit more, come out of the room, the student will kind of do that note, we'll review the note, but we supervisors need to write another note, explaining that we were as a supervisor on the session, and then we, the supervisor, can bill for that session. So it's like a double work, but I will say also it's worthwhile because when those students end at the year, they're already shaped in the PCBH model, they understand it, they get it, and those are potential hires that you can do in your site.
Yeah, so the problem that Martha is
you run away from it.
I made some mistakes. This is where a lot of my learning came from. So in the first few years when I was working in Wisconsin, I thought that you could simply supervise a trainee and have them see the patient, have them report to you, and then have some face-to-face time with the patient on that visit in order to bill for that visit. I subsequently and quickly found out, no, you cannot do that. The state of Wisconsin doesn't pay for trainees the way they do medical residents. So for a medical resident, yes, the resident can go in, see the patient, come back out, precept with their preceptor, and the preceptor doesn't even have to go in the room a lot of times. They just have to co-sign the note. If it's a certain level visit, they do have to go into the room and in order to bill for that level of care, or if it's Medicare. Right, and so that does not apply, is what we're saying. That does not apply to trainees in behavioral health. In order to bill for a visit, you have to meet the criteria as a licensed provider, face-to-face with that person. So in Martha's clinic, which used to be my clinic, we then decided for at least some of the patients, we try to recoup some costs by having the supervisor in the room with the trainee for the required amount of time, and then step out of the room as necessary. And then, of course, there's that ridiculous double documentation of notes that makes no sense. So we're trying to advocate in the state for and nationally for really true parity, which is to say, if you're going to pay residents for providing this level of care, why would you not pay behavioral health trainees and supervise them, which would make a huge difference as far as access to care nationally. But important point that Martha brings up, that you cannot bill in that same way.
Could you just come back to the Medicaid reimbursement, because that's one of the things that actually had us lose our appetite a little bit for integrated care, was that we had so many Medicaid cases that we couldn't get reimbursement for. And we were constantly pulled back into just a straight behavioral health model. So what's going on with that? And you kind of said June was the target there. What's behind that, and how sure are we that that's moving forward?
So what we put there, or Martha put there for June implementation, was just for the collaborative care model implementation. So that's just COCM. That's where you have the care manager and the consulting psychiatrist billing under the physician for a lot accrued time. So if you're just referring to that piece, this is straight from the state. We got early wind of this a few weeks ago, that the state was putting this out and requesting that key individuals comment on it. And they indicated that they're shooting for June implementation. So I think this has been in the works for a while. I would be surprised if it didn't come out and you didn't see a notification come out probably within the next week or two that this is turned on and ready to go. So from that side of things, I think that means that you would be able to get reimbursement for, at the very least, 2 major payers, because Medicare already reimburses those codes, and then you would have Medicaid. So if that's the bulk of your payer mix, that would be fantastic news. That doesn't mean that all your private payers are going to pay. So you'd have to investigate there, whether that's going to work or not. And the tricky part there is that you can't treat patients differently based on payer status. So you'd have to offer the service potentially to some patients that you knew would reject the service because they'd have to pay out of pocket. Essentially, they'd be billed for the entirety of the service because their payer is not going to reimburse for that service. So it just depends on the payer mix, really, how you want to strategize. For the other codes, obviously Wisconsin Medicaid does reimburse for those. And again, that's not setting specific. So they're not going to just differentiate. There's no way they know, that, oh, you're billing a 90832 from a primary care clinic, or you're billing 90832 from a therapy office in an independent practice. Again, unless you're a DHS 35 certified entity. So that, you can bill that today as long as you're a Medicaid provider. Does that answer your question?
Yeah, that's helpful because because we do use the COCM model in one of our pilots in actually up in Sussex, but the Medicaid was really the hang up, in terms of the appetite to persist with that. But maybe this will open the door. I think what the fallback was just to use the regular codes, but you know, the time frames are a little bit different, and it doesn't
That's
really
right.
fit the model quite as readily. So
That's right.
yeah, that helps. Thanks.
Yep. Yeah. No. So I think for your implementation of that site, do you know what your payer mix is?
I'd have to look it up at that site, but I know that the patients that were being referred, you know, again, that the physicians wanted the help with, were probably heavy on the Medicaid side, and so, you know, that becomes the issue. I mean, who in society, you know, is going to need our services more than anybody, really? I mean, it's like every place else.
Sure.
Yeah.
Yeah. Yeah, that's great. And just instructive for all of you to make these decisions, just like John is talking here, make them based on the actual proportion of your population that's going to have that need, right? So absolutely, you're going to have, for behavioral health services and primary care, your uninsured and your Medicaid folks are going to be disproportionately represented in the group of folks referred to these interventions. So you can't take your overall clinic payer mix and think that's what's going to happen, right? So just, you have to sort of budget for that when you kind of design this, which is why I think a lot of folks haven't implemented COCM in Wisconsin, because if you do serve the Medicaid population, you're going to have a lot of unreimbursed care.
Well, we have 7 more minutes. Any other questions, comments, impressions?
Well, I think I can wrap up by saying I hope that we don't make this sound too imposing or too difficult of a thing to do. It's actually fairly simple conceptually. So when we go in and implement, like, billing itself is not a huge deal. And as long as you have some technician on your billing side who just knows how to, you know, for certain situations, put in the right modifier to make sure that some bills go through and are not rejected. You know, certainly on the clinical side, the clinician side, it's a very easy thing to do, to bill, as long as you understand how to bill appropriately. If you have good templates like we talked about last time for your documentation, very easy to document. So none of this should be onerous or cumbersome. And if you know how to do basic budgeting and understand your payer mix, you can plan for an approximation of what you might recoup from all of this. So that part really shouldn't scare you from implementing integrated care. The complexity side of things usually comes with the same complexities with billing across the board at your organizations. So knowing how much, you know, knowing what your revenue cycle looks like, knowing how much you're getting paid, like actually paid for your the services you're providing, and having the metrics that will help you gauge what you're actually producing as a service. Those can get a little bit complicated, but if you have some good systems in place that are pre-existing, it shouldn't really be that much different. Here, you're just going to be tracking these specific codes and these specific claims that go out. And you should be as aggressive as possible about pursuing, why was that claim rejected? Or why is Blue Cross rejecting all of these 90832s? Or why are they rejecting this health and behavior code? Because a lot of times it's just silly errors. It could be a silly error in your claim system where, like, a certain modifier was attached or wasn't attached to the claim. Or it could be on the payer side that they just have a system glitch and they're like, oh, we should have been paying for all that. Sorry, you know. So if you have a system to catch those sorts of things and then try to rectify those issues, 9 times out of 10, I found when I face those issues, you can actually fix those problems. But a lot of times what happens with clinics, especially because this is such a small proportion of the overall organizational budget, a lot of times organizations won't pay attention to it, sort of a bigger fish to fry, and then years will pass and you don't realize that you are providing a lot of unreimbursed care. You're pushing those claims through, but you're just not getting paid for them. And that's not a good way, obviously, to sustain this kind of work over the long haul. So again, this is not something, it's not rocket science stuff. It's not really that hard. You can get it done. I would say again, the most difficult part is on the back end of making sure you're actually getting paid for these services and then fixing any problems that arise from that. You need someone managing that process, which is why I always try to make really good friends with the billing coordinator or the, claims department. Bring them donuts and anything to get the data I want on our revenue.
Well, thank you everyone for joining. Don't forget to send your names to Jan, and if you were on the same call, to send all those individual names to her. I will be also emailing the document that Neftali shared with you today on the chat, so you have it through your email as well, together with the presentation of today's.
And I just remind everybody that you guys can request one-to-one consultation with Martha and Neftali and Julie and their team. So if you want to do that, let me know and I'll get you the calendar to request some one-to-one. But they've done a number of one-to-one consultations with people in this group that have gone very well. So feel free to do that.
Have a great week, everyone.
Thank you.
All right.
Thank you.